Welcome to the deep dive. Really glad you could join us today. We're about to dive into sympatholytics, that really fascinating class of drugs that, you know, work on our sympathetic nervous system. And it's important to note, our whole exploration today comes straight from the really detailed notes and lectures of Dr. Navaneeth.
That's absolutely right. And these aren't just, pills. They're incredibly precise tools for clinicians. Understanding how they work, really getting into the mechanisms is, well, it's vital for fine-tuning that whole fight or flight response, bringing things back into balance.
Okay, so let's unpack that a little. Sympatholytics, basically. They affect our body's automatic stress response, right?
Yeah.
And you mentioned two main types, direct-acting ones, like alpha and beta blockers.
Exactly. The direct actors block the receptors,
Yeah.
and then you've got the indirect acting types. Those work a bit differently. They actually lower the amount of the neurotransmitters involved.
Okay, got it. So it's all about intervening in that balance,
Yeah.
dialing down an overactive system.
Precisely. Guiding it back towards stability, whether by blocking the message or reducing the messenger, so to speak.
Makes sense. So focusing on those direct ones first, alpha blockers. You said they're known for precision.
Yeah.
And they're, what, non-selective and selective types?
Yeah, exactly. The non-selective ones are, well, pretty powerful. Take phentolamine. It's a really strong vasodilator, super important in those acute hypertensive emergencies. And Dr. Navaneeth really highlights this. Phentolamine is the go-to drug for something called the cheese reaction.
Oh, right. That's the tyramine thing with MAO inhibitors.
Exactly, that sudden, dangerous blood pressure spike. Phentolamine is key there. And also for clonidine withdrawal hypertension. Then you have phenoxybenzamine. That one's more specific for pheochromocytoma, those adrenal gland tumors.
Okay, wow. So that's the heavy-duty stuff. What about the selective alpha-1 blockers? You hear about those more often, maybe? Like prazosin, terazodoxazine?
Right. Those are often used for BPH symptoms, benign prostatic hyperplasia, especially if the patient also has hypertension. The big watch out, though, as you probably know, is postural hypotension.
Yeah, that dizziness when standing up. Okay.
But it's interesting to contrast those with tamsulosin and silodosin. They're often the first choice just for BPH symptoms without the high blood pressure angle, because they mostly hit the alpha-1A receptor, which is more specific to the prostate.
Ah, so less risk of that postural hypotension side effect.
Much less risk, typically. It really shows you how that specific receptor targeting makes a difference in practice. More precise.
And are there other side effects with these selective ones? I think I remember reading about floppy iris syndrome.
Yes, that's one. And sometimes ejaculation issues like failure or retrograde ejaculation can happen too.
Yeah.
Things to be aware of.
Okay, let's switch gears then. Beta blockers, the LOL drugs.
Yes, the lulls. It's a pretty useful way to spot them. And what's fascinating here is the generational thing. You've got first gen, which are non-selective, second gen, more cardio-selective, focusing on the heart, and then third generation beta blockers, which bring extra benefits to the table, like vasodilation.
Right, and some of them are really widely used, like propranolol. It seems to do a lot.
Oh, definitely. Propranolol is highly lipid-soluble, gets into the brain easily. So yeah, it's used way beyond just heart conditions. Think akathisia, migraine prevention, even portal hypertension or essential tremors, and infantile hemangioma, too.
Wow, okay. And then there's nadolol. That's the long-acting one.
That's the one, known for being the longest-acting beta blocker. And sotalol is kind of unique, too. It has this risk of QT prolongation. That's an electoral thing in the heart rhythm you need to monitor carefully. Risk of arrhythmias.
Got it. So lots of variation even within the beta blockers.
Absolutely. And connecting back to those third-gen ones, carvedilol is a really interesting example. People sometimes call it a triple threat. It's got beta blocking, sure, but also some calcium channel blocking, alpha-1 blocking, and importantly, it helps reduce oxidative stress. So it's got this really useful combination profile, especially for complex heart patients.
So overall, beta blockers are staples for things like stable angina, hypertrophic cardiomyopathy, aortic dissection, that kind of thing.
Yes, absolutely core uses. And here's a really crucial safety tip from Dr. Navaneeth's notes. If someone has beta blocker toxicity, the antidote, the drug of choice, is glucagon.
Glucagon, okay, good to know. Right, so we've covered direct blockers. What about those indirect acting ones you mentioned earlier? They decrease neurotransmitter levels, you said.
That's the idea. Less fuel for the sympathetic system. Examples would be drugs like tetrabenazine and its cousins, deuterbenzine and valbenazine. These are generally used for specific neurological conditions.
Like Huntington's chorea. tardive dyskinesia,
Yeah.
reducing those involuntary movements.
Exactly. Very targeted applications there.
Well, this has been quite the deep dive. It really highlights how precisely pharmacology can step in and modulate something as fundamental as the sympathetic nervous system,
Yeah.
from blocking receptors right at the source to adjusting the levels of the messengers themselves.
It really does, and it makes you think, doesn't it? How does really understanding these incredibly specific drug mechanisms deepen our appreciation for the body's own complex controls? And maybe what other systems could we potentially approach with this kind of precision down the line? Something for you to ponder.
Definitely food for thought. Thank you so much for joining us on the deep dive today. We hope this leaves you feeling more informed and maybe even a bit more curious.